Yeah, good morning, everybody, and I'm Dr. Aibodun Moshood Adeoye. Today, in the series of the lectures, I'll be discussing management of hypertension, pharmacologic therapies, and side effects. At the end of these lectures, we want the learners to be able to list the common pharmacologic therapies that is relevant in the management of hypertension. You are expected to be able to highlight the mechanism of actions of those therapies, and also to know and list and highlight common side effects of those groups of drugs. The overview of pharmacologic therapies that is relevant in hypertension. We have the first line drugs. Under the first line drugs, we have the calcium channel blockers. We have the renin-angiotensin system inhibitors. We have the thiazide and the thiazide type diuretics. There is the group add-on class of medication, aldosterone antagonists, beta blockers, alpha adrenergic blockers, central sympatholytic drugs. We have the direct vasodilators. There is the group put under others. We'll mention them. They may not go into details. Specifically on calcium channel blockers, we have two groups of calcium channel blockers. We have the dihydropyridines and non-dihydropyridines. Dihydropyridines are more potent as vasodilators and are used often in the management of hypertension. They have less effect on heart contractilities and conduction. What readily available example in this group are nifedipine, amlodipine, and other groups that we'll find in the market. The non-dihydropyridines are less potent as vasodilators, and they have a better effect on cardiac contractilities and conduction. So specifically, they are used when there are form of cardiac arrhythmias, and maybe at a certain point in the management, it might still be used to bring down blood pressure, but not as used as the dihydropyridines. The mechanism of actions, calcium channel blockers act directly on vascular smooth muscle by inhibiting the entry of calcium. By so doing, that one will reduce the peripheral vascular resistance. We know by the time this is done, there will be better relaxations of vessels and less resistance to the flow of blood, which will in turn bring down the blood pressure. Drugs with side effects, and there are common side effects that have been reported and seen in patients using calcium channel blockers. One of such is dose-dependent ankle edema, which results because calcium channel blockers, they dilate the arteries and they have the constrictions of the veins. So now there's the pooling of blood at the ankle side. Then because of that, there will be swelling of the ankle, and we will say there is ankle edema. This is expected to be counterbalanced by the AC inhibitors and ARB, because those are the drugs that work at the afferent and the efferent, and who expects that the effect of the edema can be balanced out. The other way around it will be when we have such and we still need to use the calcium channel blocker, we might need to add diuretics. So these issues will be resolved. There's the flushing, especially with long-acting ones, and some other patients, majority, they complain of headache to calcium channel blocker. Initially, it might be there and disappear with time. Then in some cases, it becomes so severe and persistent. Some, they tolerate form of calcium channel blocker to the other. Some might have reason to complain for headache with nifedipine and not have headache with amlodipine. Well, there is the swelling of the gum, gingival hyperplasia, especially with chronic use of calcium channel blocker. It's reversible in the early stage, and we must consider this because of cosmetic reasons. We have the calcium cardiac conduction abnormalities, which, as I've earlier mentioned, is common in non-dihydropyridines. The renin-angiotensin system inhibitors, they are well tolerated. Example in this group, we have the AC inhibitors, we have the captopril, perindopril, ramipril. And under the ARB, we have the candesartan, temesartan, and valsartan. The mechanism of action is they inhibit the angiotensin converting enzyme, and the ARB blocks the angiotensin receptor. The side effects, majorly, especially with AC inhibitor, is dry cough, and is worse in blacks and Asians. Well, it cannot be ignored because most times it's disturbing, it's not productive, and it's common at night. And it's been said because it comes because of increased release and accumulation of bradykinin. Well, AC inhibitors and ARBs are not prescribed for pregnant women because it can lead to fetal renal agenesis. The normal development of kidney will be affected, and we have other birth defects. So we are not going to give drugs that will affect the children of our patients. We have the angiotensin converting enzyme induced angioedema, anaphylactic reactions, and we have the swollen gum, you have the swollen mucosa, laryngeal walls, and it can lead to laryngeal spasm. If care is not taken, it can lead to death. We have hyperkalemia, especially in the setting of chronic kidney disease or type 4 renal tubular acidosis. When we get to the discussion on thiazide, we'll see how we can balance out this hyperkalemia. Now to thiazide and thiazide type diuretics. Generally, thiazide or diuretic will enhance the potency of all other classes of antihypertensives. So, example here, we have the hydrochlorothiazide, we have the clothalidone. The clothalidone is an example of thiazide type diuretics. Thiazide type is more effective, and it has less metabolic side effect. So it's preferred when it's available and is affordable to hydrochlorothiazide. But if it's not available, hydrochlorothiazide will become handy. And hydrochlorothiazide is more available and is equally effective. The mechanism of actions, they block the sodium chloride transporters in the distal convoluted tubules. So as a side effect, we have the glucose intolerance. When you place any patient on thiazide or thiazide type diuretics, we are going to check the glucose because chronic and prolonged use of thiazide can lead to hyperglycemia. We have to be checking it. So as we are bringing down the blood pressure, we are not encouraging diabetes to set in. We have hypokalemia, like I mentioned under the AC inhibitor. When you use thiazide after a while, then there will be loss of potassium. So if you have hypokalemia here and it's been combined with AC inhibitor or ARB, the hyper there is expected that hypo, maybe they might balance out and still give us a normal potassium level. We have hypomagnesemia. We have gout because of uric acid. It might reach a level that is higher than normal, and you can have gouty arthritis. The photosensitive dermatitis, especially in the areas that are exposed to sun, we have to be full of this. It occurs, although it's very rare. The add-on class medications, we have the aldosterone antagonists, beta blockers, and alpha adrenergic blockers, central sympatholytics, and direct vasodilators. Now coming to aldosterone antagonists, they are very, very effective, especially when we have difficult to treat hypertension, resistant hypertension, or the poorly controlled hypertension. We have example, we have the spironolactone. We have the mechanism of action. It block the aldosterone receptors in the renal collecting tubules. The side effects, we have gynecomastia. You find a man having a swollen breast, a big breast and tender. For cosmetic reasons, people feel concerned, and because of the pain associated, they are bothered. You have erectile dysfunction, and in women who have non-menstrual bleeding. The beta blockers, we have set of beta blockers that are cardiac selective. That is, they work directly on cardiac muscles, so they do not affect the other parts, especially the lungs. So they have less of bronchospasm. We have some of them that are better than the other based on the study done. But for the purpose of this lecture, we just need to know the types that we have. We have nebivolol, carvedilol, labetalol, and metoprolol and natenolol. When you apply the study findings, you might find out that some are better than the other. The mechanism of actions, they decrease the cardiac output by blocking the beta-1 receptors. Also, will decrease the renin release by that same attitude, by that same action. And they decrease non-epinephrine release by blocking beta-2 prejunctional receptors. The side effects are just highlighted there, not all. We have the fatigability, easy fatigability. People feel tired, pains in muscles and so on. So we cannot ignore it. There is the impaired cardiac conduction. That's why it is advisable before you commence beta blockade. You have to check the pulse rate. You know the heart rate. If a patient is already having bradycardia, you are going to be, you have to be cautious in applying or instituting or giving patient beta blocker. Well, like I've mentioned earlier, the complication side effect, you have acute bronchospasm, especially in adults with asthma in childhood. But like I have said, there are some of the beta blockers that are cardiac selective, and they have less of bronchospasm. There is the weight gain. We all know there is problem with weight gain. So when you use it in chronic way, then there might be weight gain, and it can lead to obesity. And we know obesity will not allow the blood pressure to come down. Alpha adrenergic blockers, we have example here, prazosin, doxazosin. The mechanism of action, they cause peripheral vasodilations by selectively blocking the action on norepinephrine on alpha-1 adrenergic receptors. I will just need to state here that this same group of drugs are being used to treat benign prostate hypertrophy, BPH, and as it's shrinking the prostate, it's bringing down the blood pressure too. So we have to be mindful of this when we want to use it in combination of other antihypertensive. So the side effect is fluid retention. There will be fluid retention in the legs and other. So we have to be mindful of this. So if you are using it, and there is the need to add on antihypertensive, maybe diuretics, will be a good choice here. The central sympatholytics, they are potent antihypertensives, no doubt, and they are used in difficult hypertensions, especially renal hypertension. So the clonidine, methyldopa, alpha-methyldopa. The mechanism of action, they stimulate the post synaptic alpha-2 adrenergic receptors and imidazole receptors in the central nervous system. The side effects, we have rebounds hypertension between doses, and that's why most times their doses are as frequent, more frequent. You have like twice a day or 3 times a day, because short actions, and you need to just cluster the dosages to prevent rebound hypertension. Other things that can be depression, people not interested in the environment, and all that. So we should watch out for all this when we are using this drug on the patient. Direct vasodilators, like we have said, if you have hypertensive emergencies, they are handy. Meloxidine and adrenaline, they are patient in having pre-eclampsia or eclamptic patient. You have the mechanism of action. There's arterial vasodilatation that comes from the opening of vascular ATP sensitive potassium channels. The side effect, they have reflex tachycardia. We have to note this. If you are treating a patient and is having tachycardia, most likely the blood pressure will not come down. So we might need to give beta blockade on this, and that may be a compelling indication for the use of beta blocker. Calcium channel blockers too can lead and can give reflex tachycardia that will now make us add beta blocker. Now let me state this: if you check the blood pressure ab initio and there is tachycardia, then that patient will benefit from beta blocker. Then the other side effect is lupus-like syndrome, especially with adrenaline. Then we have hypertrichosis, which is specific for meloxidine. You have here growth everywhere, especially in the area where you should not have ear. Others, as listed here, were the post-ganglionic sympathetic nerve terminal blockers, ganglion blocking agents, then the renin inhibitor itself. You know, we have renin-angiotensin pathway, so you block that release of renin itself, so you don't need to block the enzyme, you don't need to block receptor, so you block right from the origin. Well, there are drugs that are available, but for the purpose of this lecture and for the intention that we have to control the blood pressure at the level of non-physician approach, this might not be as well needed. Now, having all this together, and we have been able to see how it is, the types, the mechanism of action, the side effects. From the International Society of Hypertension, there is this core drug treatment strategy. We have to have the strategy. I will come to the essential. If you look at the essential, under the essential here, we are going to see that the first thing we need to know is that you use whatever drugs that are available with as many of the ideal characteristics. Those are the things. We must have that. We cannot say, oh, specific drug is what I want to use and it's not available. We allow the blood pressure to continue to grow. So you use free combinations if the single pill combinations are not available or is not affordable. Thiazide diuretics you can use if the thiazide-like diuretics are not available. Like we have mentioned, dihydropyridine it will be the best calcium channel blocker that is available and that is helpful. But if it's not tolerated or it's not available, we can use the non-dihydropyridines like DTSNs or verapamil. But I've said earlier that they are more specific for cardiac arrhythmias. Well, under the optimals we have, the ideal thing would be to have maybe a single pill combinations therapy. With that, you can have two drugs, low dose, combined together. And if you come to this side, you can combine the angiotensin converting enzymes, inhibitors, with a calcium channel blocker. You can do that, and you give the half dose on both sides and combine in a single pill. But if the blood pressure is not controlled, you can go to full doses on both type of drugs, and it's still in a single pill, so you can still have that. You can give it especially in blacks. Now the blood pressure is still not well controlled, you can go into triple combination. You can still have triple drugs combined in a single pill. So you have the AC inhibitors, you have the calcium channel blockers, you have the diuretics, and you can argue. But if the blood pressure is still not well controlled, then that we have entered into resistant hypertension. So you can now have your triple combination, and you now add spironolactone or other drugs under the add-on. Well, for the spironolactone, you give the range of dose from 12.5 to like maximum of 50 milligrams. So these are important. This graph, this figure will help us. We'll be able to see how all this can be combined, and the patient will be happy for it. For us to consider beta blockade, maybe if you have a patient with tachycardia, or you have some other specific indications for use, like patient with heart failure, patient with angina, patient that has just survived myocardial infarction, patient in atrial fibrillation, or in younger women with or planning pregnancy. So this is what can be done. And to me, if you can apply this, we'll be able to control the blood pressure, and a drop in blood pressure up to like 20 millimeter mercury of systolic and 10 millimeter mercury of diastolic will prevent cardiovascular events. So we need to apply all this. As I want to appreciate you for listening. We're listening to questions. We might not be able to say everything at this lecture, so we'll be here to address some questions. Thank you very much.